Alright, so this one we did about 4 or 5 months ago, but I had to whip this shit together, so we're gonna just kind of go over the same stuff. Syphilis, OCPs, and then PCOS. So, starting out with syphilis. Oh, I forgot to. Alright, well anyways. So, we have the spirochete treponema which is the causative agent here. And it is a spirochete. Can anybody name me the other 2 spirochetes of note?
Borrelia and Leptospira.
Borrelia burgdorferi and Leptospira, yes. So, in primary syphilis, a patient is most likely to present with what complaint?
Painless chancre.
Right, a painless chancre. And if it's available, how would you visualize this?
Dark
microscopy. Yes. And so there is the VDRL is positive in about 80% of patients, but it is not specific. So, secondary syphilis. Oh, okay. So, anyways. All right. So, anyways, primary syphilis. If we don't treat it, then it'll progress. What is the treatment for syphilis?
Penicillin.
Penicillin. If they're allergic? I believe it's doxy or cefotaxime. You can also use amoxicillin for children under 8, I believe. That's in Fisher Farm, I know. So if we don't treat it, then we'll move on to secondary syphilis. And what I've heard from some providers, they'll say that a patient won't present until they've reached secondary syphilis, because since this is a painless chancre, it's normally on the genitals, so it's kind of an embarrassing reason for a doctor's visit. So a lot of people are just like, it doesn't hurt, it'll probably go away. And it does. But then it turns into secondary syphilis, and this is when most patients will present. So what do you see with secondary syphilis? Rash, and what is very pathognomonic of this rash?
Palms and
It's on your
soles.
palms and toes. Yeah.
Right. What other kind of symptoms might we see in secondary syphilis?
Condylomata acuminata. I think is what it's called.
Condylomata lata, actually.
Wrong one.
So yes, we're gonna have these nasty, warty, barky-looking kind of genitals, and you do have to remove these. Pretty nasty. So since the VDRL is non-specific, we go to a more specific test, the FTA-ABS. Don't ask me to remind you what it stands for. I don't recall. And so, if since we've moved on to systemic syphilis, we could end up with tertiary syphilis. And do we remember what progresses in tertiary syphilis?
Prostitutes people. Argyle-Robertson people.
Argyle-Robertson people. Do you remember what the mechanism for Argyle-Robertson is?
What's it? Constricts on accommodation.
But
doesn't react to light.
Doesn't react.
Right. Doesn't react to light, but there's no. Right. Doesn't react to light, but it reacts to accommodate. But it accommodates. What is another feature?
Neurosyphilis.
Other neuros.
We got neurosyphilis, yeah. Gumas, yeah. Right. So we can get aortitis because of the vasovasorum destruction, neurosyphilis or tabes dorsalis, and then the gumas. And like you said, the prostitute's pupil. So I think it was Golion. I'll say it again. So the aortitis is the vasovasorum destruction. The vasovasorum literally means the vessels that supply the vessel. So the aorta, since it's so big, it has its own microvasculature supply. And essentially, all of these pathologies, the chancre, the lymphadenopathy, the condyloblata, all of these are essentially vasovasorum destruction, just to a smaller degree than at the aorta. So it's all these mini vessels all around here that are being obliterated, and it's causing all of this stuff. So it's a vasa obliterans disease. And then you test spinal fluid, and the additional test you add here, tertiary PCR. How about congenital syphilis? This is a torches infection. So what are some of the manifestations we might see here with the kitties if they're born and mommy was naughty?
Hutchinson notch teeth and the
Hutchinson notch teeth.
Saddle nose.
Saddle nose with the, what is this called?
It's like the snuffles.
Yeah, snuffles. Then this arrow is pointing to
Facial abnormalities.
You have these
it's
like
this
creased mouth corners. What is it? Saddle nose, Hudson teeth, mulberry emotional. Ah, yeah. Regards. There you go. Linear scarring at the angles of the mouth. And yeah, saddle nose, notch teeth, mulberry molar, short maxilla. Oh yeah, saber shins, and yes, cranial nerve 8 deafness. Okay, so to prevent and treat mother early in pregnancy, as placental transmission typically occurs after the first trimester, before the second. Okay, so do you have any questions on this? Nope. Okay. So we'll move to PCOS, commonly known as Stein-Leventhal syndrome. So the pathophysiology of this is essentially a hyperinsulinemia or an insulin resistance, which, by the same mechanism of the insulin resistance, causes a hormonal imbalance, which leads to an increase in LH and FSH both. But the ratio of LH is way higher than FSH. So you're going to have an increased LH to FSH ratio. What is one that is pretty tough, a pretty obvious giveaway for PCOS for ratio.
3 to 1.
3 to 1. Ooh. 3 to 1 LH to FSH ratio. So both will be high, but LH will be crazy high. And this is because we have changed hormonal feedback, because we're going to have an increase androgens from theca internal cells, because you've got LH, so much LH stimulating all these Leydigs. They got more testosterone, but because of testosterone, it can be changed into no, I'm having a brain fart. This is probably
Estrogen.
Yes, thank you. I couldn't remember which one. Estrone. So anyways, you're going to have peripheral transition of testosterone to estrogen. So that's where you get to some of this stuff. So on ultrasound, that's what I was trying to say. So with this increased amount of androgens, you're going to have follicles inside of the ovary expanding and getting larger, but they're not actually maturing. So what you're getting is these massive amounts of cysts that are trying to get to mature size, but they can't actually mature because of this hormone imbalance. So, like I said, you get the unruptured follicles, and this can lead to anovulation, hirsutism, acne, decreased fertility, and so as you can see, there's a thickening here and enlargement of these follicles, but none of them are actually rupturing. And for treatment, you do weight control because it's associated with hyperinsulinemia, and it's like a pre-diabetes disease. oral contraceptive pills because one of the issues is that you have anovulation because your endometrial lining it proliferates a little bit more, a little bit more, and a little bit more. But since you don't actually achieve ovulation on any of these follicles, your endometrial lining is just hyperproliferated, and they actually can lead to endometrial cancer because of unopposed estrogen from repeated anovulatory cycles. So you give the OCP so that you can stimulate ovulation and a menstrual cycle in order to keep this hyperplasia from occurring. And you can give clomiphene, which we're going to chit-chat about in a little bit. So I remember we discussed this a few months back. The diagnostic criteria for PCOS. Then I remember.
Anovulation.
I'm sorry?
Anovulation being one of them.
Okay.
Cysts.
Yes. Sorry, my nose is stuffed today. We've also got
late FSH.
hyperandrogenism. But the thing about this is you only need 2 out of 3 of these in order to be able to diagnose PCOS, which means that you can have polycystic ovarian syndrome and never actually have on ultrasound polycysts. So, just something to keep in mind. It's the mustachioed lady that hasn't had a period in a while. It could be. Okay. So, we have an obese 35-year-old woman who presents to her physician with a 6-month history of amenorrhea. She's concerned particularly because she and her husband have been trying for more than 1 year to conceive with no success. Results of physical exam are normal, except that the patient has noticed darkly pigmented periareolar hair since she stopped menstruating. BP is 128/88. Lab studies show an LH level of 300, an FSH level of 5, and TSH 0.7. Results of a urine pregnancy test are negative. An ultrasound shows enlarged ovaries bilaterally. Which of the following findings is most commonly, which of the following findings is associated most commonly with her conditions? Anosmia, galactorrhea, hyperglycemia, polycystic kidneys, weak pulses in the lower extremities.
C.
Hyperglycemia?
Answer is hyperglycemia. Remember, this is a pre-diabetes type of pathology. So it's associated with hyperinsulinemia and insulin resistance, which could end up leading to diabetes, which would put this patient in a hyperglycemic state. Make sense? Mm-hmm. And the reason we can say that she was a PCOS, she had amenorrhea, and she had ultrasound, enlarged ovaries bilaterally, so that's already 2 out of the 3 criteria. Did she have the other one? Oh, yeah, periareolar hair. Boom, she had 3 out of 3. All right. So I'm just going to talk about contraception and some other reproductive-related drugs. So the most common contraceptives are combo progesterone and estradiol pills, and the mechanism is progestin and estradiol. They're going to block LH, FSH, which leads to no ovulation. Now, for PCOS patients, you have to think about the fact that they already have really high LH, FSH levels. So if you give them one of these, you'll bring it down to a more moderate level where you can actually achieve ovulation. So progestin and estradiol, they'll thicken the cervical mucus, making it an unfavorable environment for sperm to find the ovum, and you'll decrease the proliferation of the endometrium, which, like we were saying, in a woman stuck in an anovulatory cycle, she's going to want to decrease the proliferation of endometrium to prevent secondary cancer. Contraindications of smokers, cardiovascular disease, migraine, breast cancers, and a lot of this has to do with the fact that you are in a prothrombotic or hypercoagulable state when you're on these medications, on progesterone and estradiol, or if you're pregnant, you're in a hypercoagulable state. So you don't want to give someone that, might have some kind of ischemia, or somebody that already has vessels that are constantly vasoconstricting or vasoconstricting. And then the incidence of breast cancer has to do with the hormones imbalance. And obviously the use is for contraception. So this is where they would work. Boom. Knock out the LH and FSH. So we got anti-androgens, and these can also be used in PCOS treatment for the cosmetic manifestations rather than the other hormonal ones. So the ones for PCOS would be ketoconazole and spironolactone, and again, this is because they have anti-androgenic effects, but in a male, this could be a problem because they can cause gynecomastia. So we also have finasteride and flutamide. Finasteride, we know, is the 5-alpha reductase inhibitor. So you use it for BPH, and you can for male pattern baldness. So flutamide is used for prostate cancer. Do we remember what other drug you use with flutamide for prostate cancer?
Doxazosin?
The alpha soprazosin.
That's another. Doxazosin, prazosin. Those are drugs you can also use for BPH because those are alpha 1.
Yeah.
Or alpha antagonists. So they'll relax the internal urethral sphincter. So those are for BPH, not prostate cancer. It's
Leuprolide. Yeah.
Okay, and my next question was, you use both of these. Which one do you use first? So this one is an androgen inhibitor, and let's see, Leuprolide.
Oh, maybe Leuprolide. That's a GnRH agonist.
Right. Check that. Yes, GnRH agonist.
Well, are you giving it pulsatile or continuous? Because doesn't it become an antagonist when you give it in a continuous fashion?
Well, so we're trying to block it in prostate cancer. So we're going to give it a full blow.
Continuous, but still, there's still like 8 increase before the decrease is seen, even in continuous.
Right. So the question is, which one do you give first?
Leuprolide. If the flutamide is an androgen inhibitor, or no?
So you give flutamide first because. So this is GnRH agonist. This is Leuprolide. Down here we've got flutamide. So you have to block the receptors first, because if you block this first, that's where you'll get that surge. And you'll get a surge of testosterone binding. And this is where they'll say that someone with metastatic prostate cancer in the back, this can like really screw up their spine or their tumor growth and all that. So you give flutamide first, then Leuprolide. I remember from Kaplan Farms loops flute. But then you have to give the flute first and then the loop. Loops loop. Doop, doop. Does that make sense?
Mhm.
Mechanism? Okie. And then we got some SERMs, selective estrogen receptor modulators. Okay, so the three main ones that we talk about are clomiphene, tamoxifen, raloxifene. Clomiphene is the one that works in PCOS. So this works at the in the hypothalamus at the estrogen receptors. So this prevents normal feedback. Is it even right here? Actually, clomiphene right here. Boom. So clomiphene prevents normal feedback inhibition and increases LH and FSH from the pituitary. So this guy is going to stimulate that so that we get a lot more LH and FSH happening. So this is to stimulate ovulation, and this is how you can treat infertility. Excuse me. Okay. So then tamoxifen and raloxifene are antagonists at the breasts and at the bone. Actually, hang on. Let me say this properly. So they are both antagonists at the breasts, but so both antagonists at the breasts and agonists at the bone. But the tamoxifen has the added issue of it has a positive agonist at the endometrium, which can increase the possibility of endometrial cancer. And the reason you would use these drugs specifically is if you have estrogen receptor positive breast cancer and osteoporosis, because they're agonists at the bone. Sorry, brain fart there. And that's all I got. Any questions?